Dear friends, now we are going to talk about the treatment aspect of cystic fibrosis. And sometime before, I have been talking about the cystic fibrosis, particularly symptoms, diagnosis, and all. Now we are going to talk about the treatment. See, it's a very vast topic. That's the reason why we divided into three parts. Part 1 telling about the symptoms, part 2 telling about the diagnosis, and part 3 now we are going to talk about the treatment. Cystic fibrosis, sometime even my days I thought it's a very rare disease. It is happening only in the Western Europe, particularly in the Caucasian. And of late, after the advent of lot of investigations, we are able to diagnose cystic fibrosis in many parts of the world. And moreover, the most important thing is now there are some drugs are available. These drugs are useful. They are called modulators, and in that way, when these drugs are used, their life expectancy become increasing. Right. Coming to the management aspect of cystic fibrosis, we have to approach this topic into 4 domains. The first, I'll talk about the airway clearance. This is a very important, because the most important thing in the cystic fibrosis is the accumulation of the mucus. The mucus, normally we produce about 1 liter, 1.5 liters of mucus in the respiratory system, more in the sinuses. The idea is, actually the respiratory organ is directly exposed to the environment. So a lot of infectious and non-infectious particles entering into the respiratory system. That is the reason why your mucociliary escalator mechanism actually constantly working and removing these secretions. So that is impaired in cystic fibrosis. Please go and see what is happening in the diagnostic. There I talked about the mucociliary escalator and all. So airway clearance can be achieved by either a mucoactive agents or chest physiotherapy. And next important thing is the nutritional support. I already said it is because of the pancreatic duct obstruction. There is no pancreatic juice entering into the gastrointestinal system, intestine. So, and there is also, naturally there is a deficient in the absorption of fat-soluble vitamins. That's also we are going to talk. Then we are going to talk about the rehabilitation, what we should do to keep our lung healthy. Then where should we use drugs, particularly the antibiotics and a CFTR, that is cystic fibrosis modulator, and what is the role of vaccines and all. Coming to the airway clearance therapy, I can approach this into 2 important things. One is the chest physiotherapy, that includes postural drainage and percussion. And we can also use some of the devices that I are going to tell about that. And we are going to talk about that mucoactive agents. Okay, these are the another group of things that actually liquefy the mucus, thereby facilitate in the expectation of mucus. That includes hypertonic saline, beta agonists, that is salbutamol or levolin in nebulization, Darnase alpha. Actually this is a costly drug, produced as a this one I'll talk later later. Then even some people use ambroxil. And what is the status of guaifenesin and N-acetylcysteine, that I am going to tell about that. See, I have been telling what is a mucociliary blanket. Actually look at the airway. It is starting from the trachea till the bronchioles. We can see the nice mucociliary system. It is a outer mucus layer, that is outer gel, and inner sol layer. That is, inner sol means solubility wise it is a little thin, whereas here thick mucus will be there in the mucus layer because of that. And whichever the particles getting trapped during your normal respiration, actually it happens from above downwards. It moves in above downwards because of the nice ciliary action. So lot of cells like basal cell, global cell, salivary, all these things produce nice mucus, and in the inner sol as well as in the outer gel layer, and anything second to that is being nicely coughed out. Of all the mucoactive agents, 3% hypertonic saline is found to be a better one, because lot of trial support, and even Cochrane database that appeared in 2018 says that 3% hypertonic saline is a very important drug in the management of cystic fibrosis, because it creates osmotic gradient, absorbs fluid from the interstitial surface, and makes the sputum less viscous, and thereby the mucus is easily expectorated. So this is what actually some of the papers say, that not only it protects the lung function, but also it has a positive or effect on the structural. It will postpone the structural lung changes and all. Coming to the other two drugs, I think beta agonist is very easily available everywhere in the world. Dornase alpha, it is a recombinant human deoxyribonuclease. It's really a costly drug. It acts as a mucolytic agent, improves the lung function, but I think it's in day-to-day basis, it's very difficult for a poor man to use all these things. So the best thing is go for a beta agonist like salbutamol or livolin. They not only relax the bronchial muscles but also open the airways and improve the mucociliary clearance, thereby postpone the ultrastructural damage. And that has been reviewed by the PubMed review in 2020. And it also says that sometimes we had a lot of interest in N-acetyl cysteine, NAC, and people started using NAC in the routine treatment of cystic fibrosis. But that PubMed review on 2020 showed there is no evidence to support the use of NAC in CF. I think this I want to share with you. I think this is my favorite topic. I think cystic fibrosis, I already said, there is a mucosal or mucociliary transport is get damaged. Whenever mucociliary transport is damaged, we have to go for chest physiotherapy. Three important diseases. One is a cystic fibrosis, and that lead to bronchiectasis. So bronchiectasis itself. Third is the primary ciliary dyskinesia. In all these conditions, chest physiotherapy plays a very, very important role. The most important thing is we have to utilize gravity advantage, that is called postural drainage. We have to make the child lie down in such a way that foot end should be elevated. Okay, that is the reason why, that is the way you can make the affected segment at the little higher level. For example, most of the time the lower lobes are involved, so naturally we have to make a elevation of 18 inches, that is 1.5 feet elevation of the foot end. If middle lobe or lingula is involved, you can make a 14 inches elevation. I think this is a very, very important. If you make the parents to understand the importance of postural drainage, I think most of the cystic fibrosis children will have a better life. Naturally, what they say, cystic fibrosis, in cystic fibrosis, postural drainage can be combined with percussion and vibration. Actually, here what we do, have a cupped hand. These cupped hands causing the effective displacement of the secretions. Actually, there is some rules also given there how to make a cupped hand percussion. That is 1 to 2 per second, 2 to 3 minutes per segment, not more than 30 minutes per session, because it may be tiring to the child. Ideally, it should be done before food, not taken after the food. Child will vomiting. Ideally 3 times per day, and ideally you have to make a surface phototopography where to make a cupped hand percussion and all. What they say, this cupped hand causes effective dislodgement of the secretion. That is the reason why actually this is very useful in a smaller baby. I'll show that. See, these infants diagnosed with a cystic fibrosis. We can use even that mask. Okay, you can you can put the child on your lap, and you have to mask the child. The air column inside the mask causes the effective dislodgement. Sometimes upper lobe, given a sitting position, may be helpful and all. Coming to the positive expiratory pressure devices, actually the principle is in cystic fibrosis, all the secretions are very, very thick. So here the patient exhales into the device against the resistance, which creates a positive expiratory pressure because the ball inside that vibrates. See, there are some magnetic balls or steel balls are inside. There are two types of instruments. One is a cappella, that is other flutter valve. A cappella, and both are working on the same principle of positive expiratory pressure. They create a positive expiratory pressure. In both these things, the patient is supposed to exhale through the instrument. In a cappella, the counterweighted plug and the magnet cause oscillations. Thereby, it effectively dislodges the mucus. And here, the advantages of the a cappella is it can be done either in a sitting posture, standing posture, or lying down. But same principle here in flutter you cannot do. You can do only in the erective posture and all. Coming to the West, I think in Western world they use West only. That's why I jokingly say that it's a very costly one. Actually, it's a mechanical device that use positive and negative pressure, and it produce high frequency oscillation. It is something like a jacket. They have to wear the jacket, and then you have to hook with the generator. Then the vest creates or inflates and deflates the chest wall, and in that way it dislodges the mucus from the bronchial walls. It's a very useful one, but only thing is it's very, very costly one. But still it is available in Western world, particularly in North Europe, as well as in US and other places like Australia and all. Coming to the active cycle of breathing, it's a very simple one, and children may be taught how to do active cycle of breathing, ACB. Actually, I always say that any people can do this because by virtue of your age, there are a lot of secretions may be happening in your respiratory system. What they say, this is a combined technique involving first is the relaxed breathing, second is the deep breathing, third one is off. Okay. In relaxed breathing, we normally breathe. The idea is you have to breathe through the nose and slowly breathe out through the mouth. It's a slow breathing. Then you have a control over you are making your CNS that you are going to breathe like that. You are giving a command. So thereby having a breathing control. Then after that, we have to make at least 5 to 10 deep breaths. Here we have to make a thoracic expansion like that. Then we have to keep holding the breath for at least 5 seconds. Then you have to breathe out. In that way you can do at least 10 times. And in the deep breathing is the one that helps us to dislodge the secretions from the respiratory system. The last one is the huff. Here huff means something like that. That is, we are doing some forced expiration through the mouth. In that way, the secretions are pushed out from the smaller upper airway. Actually, this is an active cycle of breathing should be taught in a resource poor setting. It is something like a class. In a cystic fibrosis clinic, the doctor or the paramedical worker who look after the child should make the child, older child means you can taught the child directly, and smaller ones probably after 5 to 6 years when they listen our command, at least 7 years later we can taught the technique. That is called active cycle of breathing. Next important aspect is, I already said, in cystic fibrosis, the organ, the most important organ affected is the pancreas. So the pancreas, normally the pancreatic duct get obstructed because of the thick secretions. Normally we produce around 1.5 to 2 liters of pancreatic juice. It is like an alkaline juice that entirely pushed into your small intestine. Actually, it is this along with the bile, they started the digestion, and that is not happening in the cystic fibrosis. So when there is no pancreatic juice, there is no digestion of fats, proteins, or even carbohydrates. So you have to give pancreatic enzyme replacement, that is called PERT, pancreatic enzyme replacement therapy. Actually, nowadays this replacement therapy is obtained from animal origin, and you can use that one. And we also should use fat-soluble vitamins, because there is no bile, there is no pancreatic juice. So these fat-soluble vitamins are not getting absorbed into the body, particularly vitamin A, D, E, K, and we have to supplement that. And again, the most important thing is what they say in cystic fibrosis, you have to increase the energy supply little more than the normal one. So at least what they say, you have to increase 100%, and you also to give little more proteins and fats and vitamins, and you have to monitor their growth. That is very important. Coming to the pancreatic enzyme replacement therapy, simply called as a PERT, I already said it is animal origin, available as a entry-coated pH-sensitive microspheres. Actually, these can be mixed along with the meal or just after starting the meal. It is available as a capsule. It contains lipase, pancreatic lipase, protease and amylase. So, you have to use in the dose of 1000 units of lipase. If you use this, then it automatically get calculated. So even if it is a pancreatic obstruction, since you are supplementing lipase, protease and amylase in the form of microspheres along with the meals, they have a better life. Only thing is, you have to make the child, you have to make the parents to understand the importance. If you say that it is something like a tablet, they may not understand. So you have to make the parents to understand your child will have a normal growth, normal fat, normal protein or normal functioning of system only possible if you use this pancreatic enzyme replacement therapy. And it is available in the market as several names as Creon, Pancreaflat, and all these names is available. You go and see the literature. You can put them on the dose of 1000 units of lipase per kg per ml, but don't exceed 5000 per kg per ml. Coming to the vitamins, I already said, since there is no pancreatic enzyme, there is no fat, there is a malabsorption of vitamins like A, D, E, K. Particularly vitamin, you all know, vitamin A is very important for eye, and vitamin D is very important for many functions, particularly bone and teeth. And vitamin E is alpha-tocopherol, and vitamin K is a phytoquinone. All these things are all have their own function. So you have to use this in the recommended dose. What is given here, you have to use minimum of 400 units. I think some people say even 800 units of vitamin D should be used, and vitamin A 1500 units per daily, and vitamin K 0.3 milligram per K, and vitamin E is 100 units. I am telling you a very minimal one. You have to increase according to the age and requirement and all. Coming to the antibiotic, I think somehow cystic fibrosis is a compromised situation, immune compromised situation. So they succumb to the infection very fast. Since there is no mucociliary mechanism, they get faster infection. So they get cough, and very easily they go for infection. So they have a mild fever, increased cough, and how to suspect that they already had a pulmonary exacerbation. Simply you ask the parent, they say, yes, my child is coughing little more, he get lot of sputum, he had a fever yesterday night, and the X-ray also showed some new infiltrates, and his breathing also is increased. In such a situation, you have to make a diagnosis of cystic fibrosis with the pulmonary exacerbation, and the ideal thing is you have to send them for sputum. For example, smaller children, they are not able to do sputum mean, then you have to go for induced sputum. So most of the times, in earlier days, they may show almost all the organisms, but when the age is increasing, they get infected with either Pseudomonas aeruginosa or Staphylococcus or Burkholder. These are the common organisms. And once they enter into the system, it is very difficult to eliminate them. So you have to be very careful. So that is the reason why we have to go for sputum culture and all. And if there is situation is not warranted to do for testing the sputum and all, sometimes your empirical therapy can be done with a co-amoxicillin. Only thing is you have to choose a little higher dose, and it should be continued for at least 3 weeks. This is very important. And the ideal thing is, what they say, 50% of the CF patients get infected or colonized before the age of 5 years. Actually, it's very, very important. So you have to see the child should not get back Pseudomonas aeruginosa, because CF respiratory tract very easily colonized with Pseudomonas aeruginosa. So if you make a diagnosis of acute infection of Pseudomonas aeruginosa, it should be eradicated. Proper antibiotics should be used, and most of the time these children may be put on tobramycin as a nebulization, and they continued for a long month. So why I am telling is, Pseudomonas is the one infection. Once they colonize, they slowly go for infection, chronic infection, and they have a tendency to form biofilm. Once the biofilm, that is something like a coating surrounding the organism. This coating protects the organism from phagocytis. Even neutrophils come there, it is not able to kill them. So slowly the damage becomes progressive damage of the respiratory system. That's the reason why many people say that if you document Pseudomonas at least 2 times, you have to make a diagnosis of chronic Pseudomonas infection. Put them on tobramycin, 300 mg twice daily, and you can give alternate month also, at least for 3 to 6 months. And some people say that azithromycin is a very, very important drug. Somehow, not only as a chemotherapeutic agent, but also it is by virtue of its immunomodulation, it reduces the inflammation, and it also prevents the biofilm formation of the Pseudomonas aeruginosa. I think this knowledge is very important. Coming to this ABBA, you all know allergic bronchopulmonary aspergillosis is usually happen in a severe forms of asthma, as well as in severe forms of cystic fibrosis. Actually, it is not an infection, it is a hypersensitivity reaction to aspergillosis. You have to remember what is infection, what is hypersensitivity mechanism. Here, it is hypersensitivity mechanism. So, the children, naturally CF children suddenly will have a more of pulmonary symptoms, what I said, and there is a lot of infiltrates may happen in the chest X-ray and all, and sometimes you have to take an X-ray, means at that time it may show a lot of infiltrates. How to diagnose ABBA? Very simple thing is, what they say, now go for specific IgE against aspergillus, and anything more than 0.35, it's a diagnostic. In some places you can use positive skin test also for aspergillosis. Along with, if the total IgE is more than 500, previously we have been using cutoff of 1000, now the latest recommendation says 500, and the presence of eosinophil, absolute eosinophil more than 500. This all says that of that the first 2 is very, very important. It is a sign of ABBA. You have to naturally treat the child either with glucocorticoids or with hydroconazole or with the both. Coming to the vaccines, I think I already said cystic fibrosis is an immunocompromised situation. They succumb to the infections very fast. So you have to naturally protect these children against H. influenza, pneumococcus, varicella, and these children should be benefited with influenza vaccine every year. Otherwise, once they succumb to influenza, there is a flu, seasonal flu, their course is a dramatic one. They need hospitalization and all. Again, CF children are particularly prone to get chickenpox pneumonitis. So you have to cover these children with the chickenpox vaccine. And you should not give all these vaccine when the child is on some oral steroids. That is very, very important. Otherwise, your purpose get defeated. I think this I already shown in my last lecture and also while discussing on the symptoms, discussing on the diagnosis. Now this is a very important thing, and cystic fibrosis, the mutations where diagnosis are getting added and adding. So now it is roughly we have find out 2500 mutations. Actually all these mutations are grouped into 5 groups: group 1, group 2, group 3, group 4, group 5. And group 1, it's a very bad one because there is no CFTR protein at all. I think these children is a very severe form. They die very soon after the death, birth and all. And the second one is, here there is enough protein, only it is a partial mechanism. It's not getting reached to the site. So there is a defective trapping in the Golgi apparatus. I think that is what happened in the delta F508 mutation, and that is the reason why people started inventing some correctors, how to correct the trapping. And I am going to show which are the correctors that we are using in the treatment of cystic fibrosis. And again, after producing the protein, it comes out of the nucleus, it gone to the endoplasmic reticulum, it has gone to the Golgi apparatus, then finally when it reaches the site, it has to be activated by the ATP mechanism. That is not happening. So ATP, it doesn't respond to ATP. There we have to use potentiators. Okay. So these two drugs nowadays they are collectively using, namely correctors and potentiators. They're calling it with a single name, modulators. Sometimes fourth group and fifth group are considered to be very mild because one is functional defect, one is anatomical defect. The amount of proteins available in the site that act as a chloride channel is very defective, is very less, and that is the reason why no single CFTR modulating therapy works. Many people may be having some 2 or 3 mutations together. That's the reason why we have to use collective modulators. Instead of separate drugs, we have to use both correctors and potentiators. So what are the CFT modulators? Nowadays triple combination therapy is used. Sometime before you have been using only ivacaftor. After that we find out, after our knowledge about this 5 groups of CF, we started using elixacaftor and tezacaftor, and I think these are all acting as a one group, and ivacaftor is the one as a potentiator like that, and this is available as a fixed dose combination. Okay, and it should use daily, but it is really a disease modifying drug, and it dramatically reduces both GI and pulmonary manifestation, but the cost is very, very high. Even in US the cost is around $2,400 per month. It's very difficult. That's the reason why it's not freely available in India. So coming to the message, now I am discussing about the cystic fibrosis treatment, and initially I talked about the symptoms. In the third lecture we are talking about the treatment aspect and all. In the second lecture I told about the early diagnosis. So whenever you suspect cystic fibrosis, early diagnosis is very important, and that increase the quality of life and expectancy. Of late, what they say, in 20 years before or 30 years before, they hardly reaches the second decade. Now many people are the life expectancy is passing beyond the fourth decade, and only thing is we have to make the parents to advance and understand the importance of the airway clearance. That is very, very important. I think in my follow-up clinic I always insist every visit how to do airway clearance technique, particularly the postural drainage, cupped and percussion, along with nebulization with normal 3% hypertonic saline. Naturally, because of the pancreatic duct obstruction, you have to put them on regular pancreatic enzyme replacement therapy along with the fat-soluble vitamins. This is very, very important. If you put them, their growth may be very, very normal, and most of the time they suddenly go for infection. So it has to be prevented by vaccines. These children should be benefited with all the available vaccines. You should identify whether the child is going for pulmonary exacerbation, and you have to use antibiotics judiciously. I already said modulator drugs plays a very, very important role in the management of cystic fibrosis, and that is the reason why in Western world they are using CFT clinic, so that they can talk with the parents for a long time, and the paramedical will talk. They should know about the cystic fibrosis, how to counsel the parents. Once you make, actually the parents or love their children lot, they want to do many things, and you have to make them to understand the importance of this replacement therapy as well as the airway clearance. Once if the parents understand, I think the life expectancy of the cystic fibrosis child may be prolonged. I think this may be a last slide, and today I think babies born with the cystic fibrosis have a life expectancy over 40 years. That is what the situation. So people who happen to see that, I kindly pass on this message, so that how to diagnose early. I always say it should be diagnosed even within first 3 months. If you make first 3 months, then the life expectancy may be increased, because once you leave that, there may be a pseudomonas colonization. Once there is a pseudomonas colonization, they will go for lung damage very fast. The life expectancy may be reduced. That's the reason why you have to make a very early diagnosis. If you make an early diagnosis, then babies will go with a life expectancy of more than 40 years. Thank you one and all.